Good afternoon, everyone, and welcome to the post-lunch session. And we have session on technology, that is CGM and AGP workshop. And we have two pioneers of technology in India, CGM and AGP, Dr. Bansi Sabu and Dr. Manoj Chawla. We will introduce Dr. Bansi Sabu. As such, he doesn't need any introduction. And he's the Chief Diabetologist and Chairman in Diabetes Care and Hormone Clinic at Ahmedabad. He was the past president of RSSDI. He is the Honorary Secretary of Diabetes India. And he'll be today taking a topic whether we are migrating from SMBG to CGM. And it's a very interesting topic because CGM gives a whole lot of perspective regarding the retrospective data of time in range, and which can help us decide the treatment part and the last 3 months profile. Whereas SMBG gives us the diabetes blood sugar level at that point of time, and the frequency depends on the patient or how many times he is going to do. So, sir, over to you, Dr. Bansi Sabu.
Thanks the scientific chair, and thank you chairperson for this workshop. We know that there will be few persons in the workshop, but workshop is made for few persons only to understand it better. That's what we thought of that workshop should be. And the second is wherever you are doing the convention, you have to see how many number of holes are there, and accordingly you have to justify the place where we should keep the workshop. So and less the number, you don't worry, we can still have a better discussion. That's not necessary that you should have hundreds of people to listen on it. Now the topic is very interesting, which we had capped. It is, are we migrating from self-monitoring of blood glucose to continuous glucose monitoring? And this is a change which we are seeing in 2020. I'm sure before 20-25 years, in 1995, when we had a data from UKPDS and DCCT, we were, as a student, I was just passed out from MBBS and MD days, and we were not able to understand that how one can do 3 or 4 times a sugar, because that's what it was done in DCCT trial, and they could achieve a tight glycemic control. At that point of time, even the glucose meter was not available to our public hospital. In the hospital, it was not there, rather to buy for a patient, which was real difficult for that point of time. And at the same time, there was also people were not doing the A1C so often. I mean, A1C was considered only for some of the patients, and we used to titrate the dose by just checking the patient fasting blood glucose level or postprandial blood glucose level, which used to come from the lab. This is what I have seen. I'm sure Dr. Tripathi may share his view also, that before 50 years or 40 years, how we were treating diabetes. Urine was the only parameter. So, I mean, today we all get surprised that, it is how we were managing. I mean, today if you ask someone that only by checking patient one blood sugar of a fasting or one postprandial blood glucose level, and you are just changing his therapy, you are just titrating the dose of patient's pre-meal or post-meal type of glucose level, is it possible? You will feel that no, it is not possible. So, similarly, from SMBG, we are migrating from self-monitoring of blood glucose to continuous glucose monitoring. We all know that managing diabetes is not easy. It's really difficult. There are a lot of challenges when we are talking of managing diabetes, and particularly when we talk of type 1 diabetes. Patients who are almost like on insulin, type 2 diabetic, long duration of diabetes, the patients who is having risk of hypoglycemia, patient of chronic renal failure. So there is a lot of difficulties about the food. Food is, you just can't have every day the same type of food. Even for a type 1 diabetes, I don't know how many of you are writing, but I write for type 1 diabetes a weekdays and weekends prescription separately, because they may have different type of food also, all these things. There are medication which are also responsible for their sugar to go here and there, and that's the reason every time that they have to check, ideally a type 1 diabetic patient, and that is what we recommend, that they should check pre-meal blood glucose level every time. They should count how much carbohydrate they are going to eat, and they should use the insulin carb ratio and correction dose both for taking care of the next meal. And it's a continuous 365 24/7 procedure, and that continue lifelong. There is nothing like that they can change. And this is the what the change is going to happen from self-monitoring of blood glucose to the continuous glucose monitoring. It is the activity which is also very important. Rather, there is a separate workshop which we have done with a adjusting the insulin pump or adjusting the dose of insulin or adjusting the blood glucose monitoring along with the physical activity. Now you have a type 1 diabetic patient who might be doing marathon running, or you have a type 1 who is doing a intensive physical exercise in the gym, and they all require also the glucose monitoring more frequently, and they require adjustment in their insulin doses as well as in other oral anti-diabetic agents accordingly. There are some biological reasons also, too little sleep, jet lag, and many more things are there. Environmental factors could be there. I mean the expired insulin and something like that, and it is the behavior and decision. These are the multiple reasons for diabetes to manage, I mean not to have very good control in a person with diabetes. Now 20 years ago, this paper is by Roger Maze. I was there with Roger Maze exactly in 2005 in his center only, and it was a 5 days program. And we were there, and at that point of time, 3 days, he had put all the students who were come from all across the world, put the continuous glucose monitoring. So I remember my first CGM which was installed, and I had seen it was in 2005 only. And he has written one paper that 20 years ago, many physicians treating people with diabetes thought the use of home blood glucose monitoring of any sort was a waste of time and expense. Now, this is, I'm talking in 2005. When he thought of and writing a paper, it was 1985. Why I would use this paper now? Because still we think in 2022 also that in 2005 actually we were thinking that it is of no use to use self-monitoring of blood glucose to use multiple times. The major challenges is reliability of patient data, the glucose monitor which they were using, how reliable it is, whether because many of our patients still continue to test us. They do the glucose meter, the glucose monitor, and they again try in the blood sample also in the lab. Sometimes they put the venous blood also on it, and multiple problems are there. Interpreting patients' data, large number of blood glucose results between the visits also, and time constraints in a busy medical practice. And this is very important, which I had seen. A patient comes with a hundreds of blood glucose report to you. He may show you in last 3 months some 100 reports on a piece of paper, and actually a busy clinician is so much busy that he does not have a time to look into it, and that also demotivate the patient for doing self-monitoring of blood glucose too. The Einstein research developed a series of standardized graphical presentation. Goal was to help physicians quickly recognize a glucose pattern and trends. And actually, the Roger Maze has worked on it, that actually he had collected these hundreds of thousands of the reports, and he tried to make in a graphical form. And since then, glucose monitoring technology has been significantly improved in terms of accuracy and data management. That is what he has done in the form of ambulatory glucose profile. Now, how to help patients to identify their bright spots and landmines, and this is what before meals you have to do, after meals which you have to do, before bed one has to do, and this is what we ask the patient at least 7 times a day. That's not possible sometimes other than in a randomized controlled trial, but what we do is you can do every day 3 times a day, and in a weekends you can do 7 times, or one weekend at least on Saturday, on Sunday you can do 7 times, and in other weekday you can do 7 times, and otherwise 3 times a day, and you can adjust the dose. If hypo and hyperglycemia is suspected, then again you have to monitor at that point of time. So it's not just 6 or 7 times, it becomes 8, 9 or 10 times also. And checking in pair, I mean that is what pairing, monitoring in a pairing, when you are doing before breakfast, after breakfast, before exercise, after exercise. So something when we are doing with a pairing of that, that is also known as the pairing monitoring, which we do for the self-monitoring of blood glucose. It gives you an accurate check on an average blood glucose level, but it misses the glycemic excursion across the dose. And this is very, very important. And I have a patient, and many of you must have seen the patients after using the continuous glucose monitoring. And this graph which I give you, that one of our patients, suppose he is monitoring 4 times a day, and that is what recommended. I mean in DCCT what they had asked, that you do 3 times a day. You do 4 times if patient is having hypo and hyperglycemia. You do 7 times a day on one particular day, or 8 times a day, and this patient was actually doing, you can see here 1, 2, 3 or 4. The same patient, when you put on a continuous glucose monitoring, Things are completely different. You are thinking that all 4 reports of this patient was absolutely normal. As per the, it is always between 90 to 120 before meals, and post meal also it was fine, 140 or 150. But if you are doing continuous glucose monitoring, you will find that, there are some hyperglycemic peak and there are some hypoglycemia too. Here you can see there is a hypoglycemia, there you can see hyperglycemia, and that is what whatever the number of times person is checking the sugar, in between there is a hypo and hyperglycemia peak. So I always tell, the self-monitoring blood glucose is like a still photo, and a continuous glucose monitoring is like a videography of it. Like self-monitoring will tell at this point of time, if I take a photograph of this, I can show that there are 40% sitting or 20% sitting in this room. That's one time, but after 5 minutes, you all may go away. And it can only show with the continuous glucose monitoring only by videography, whether they all 20 were awake in this meeting, post lunch, whether they were all listening it. This all you can know by continuous glucose monitoring or by continuous videography. You just can't get with a one single still photograph, which we do with a self-monitoring of blood glucose level. CGM's principle, I will not talk much. It is an interstitial fluid glucose level. It is not, new thing in our country. We are using since last almost 15 years. As I told you, continuous glucose monitoring in our India, it was available and most of us have used it. But current glucose monitoring devices have minimally invasive enzyme coated electrodes. So continuously evolution had happened. It used to be only for 3 days, then 5 days, 7 days, and now we have even 14 days continuous glucose monitoring device which is available to us. As I told you, CGM capture after meal spikes, and it gives you the trends of glucose, and that is what is required. Why you need the trend? You just don't need only some glucose value to adjust the dose, because we don't want our patient to go in hypo and we don't want our patient to go hyperglycemia. I will talk little on time in range. That concept had come after we started doing the continuous glucose monitoring for our patients. So one is raising the doubt and another is demystifying. The blood glucose monitoring still leaves the question, I am at 160. Am I going to go up or down? We don't know, because at 160, whether patient should be happy or patient should be unhappy, we don't know. Whether after 2 hours of a food, if he thinks 160 is fine, but we don't know how much fat he had consumed. We don't know whether his peak will be coming after 3 hours or not. We don't know how much complex carbohydrate he has taken and what will be the peak of this person. We don't know any idea. And suppose patient has taken more amount of the insulin, probably he may have at 160 at 2 hours may be normal, but maybe at 3 hours or 4 hours he may go in down. That may be at 60 or 55 also. You don't know. You don't know what type of insulin he has taken. If he has taken a regular insulin, which may lead to hypoglycemia after 4 hours, he may have a patient of a gastroparesis where the peak may come after 3 or 4 hours also. And these all things you just cannot pick up by a single report of 160 milligram. If I am going up or down, I am confused. It is the continuous glucose monitoring can tell me that whether I am going down, whether I am going fast, down also, how fast I am going down, that's also very important. So it's a continuous glucose monitoring can provide the answer and more complete picture to allow the patients to make the best decision about their diabetes management. And when we teach the patient, when we try to educate the patient, when we want to empower the patient, that you have to take care of your diabetic management. This is the patient who is taking care of his diabetes for 365 days. He can't meet you multiple times. He cannot afford to meet you. Rather, he can meet you once in 3 months. To diabetologist, endocrinologist, maybe once in a year. He might be meeting his primary care physician maybe once in 2 months or 3 months. He can't afford to meet you multiple times. We have to empower the patient, and for that, these type of devices are required for him to monitor himself and him to adjust his doses also. There are type of continuous glucose monitoring. We have retrospective, that is professional one, and we have real time, and we have personal, that is flash glucose monitoring. I'm sure we have used both type of glucose monitoring system in our country. We have a professional one where the monitor is on by the clinician. So patient has to put the sensor and patient has to come back to the doctor's clinic to get the data, and you get the retrospective data. There are advantages of retrospective data. There are disadvantages of the retrospective data also. It is for 7 to 14 days. You can download all the reports. There is no alarm. Retrospective review of the patient. You have to understand that last 7 days what you have done, last 14 days what you have done. And the personal is owned by the patient. Patient monitor himself. You can come inside, please. The patient can monitor himself, they can see the value by themselves. There are alarms for up and down, and some require some calibration also. So some of the glucose monitoring system require the calibration also, and they can be interfaced with the smart device, and that is what the types of continuous glucose monitoring which are available to us. As I told you, the Prustal one, the Guardian Connect, which is available to us. We also have the Dexcom, and now new latest which is available to us with Circa CGM. It's a continuous glucose monitoring device by Circa, the Aris. We also have the intermittent scan, which is flash glucose monitoring by Abbott. Again, it is available in two forms, which is Libre Pro and Libre. So we have both, again, the professional one, and we have the one which is owned by the patient himself also. The real time is better than intermittently scanned CGM. Now, these all three have their own advantage and own disadvantage. Now, if you talk about the internationally, the Western population, when you can educate the patient, so much so that patient can have the real-time continuous glucose monitoring, and simultaneously he can act also on that. Suppose you are not confident that my patient, if he is going to have the 90 sugar middle of the day, what he is going to do, because you have to tell the patient that if your sugar comes 252, what he has to do, and when your sugar comes 92, what he has to do. So somebody who is on a real-time continuous glucose monitoring, you have to empower the patient so much so. You have to educate the patient so much so that he should know what to do with that sugar report. If you are not confident, then you use the professional one for some days, and you get the report, and you try to teach and educate the patient. See, your last 14 days report shows this and this. Then you have a flash glucose monitoring, when every time you have to do the flashing. In compared to flash, you have a now continuous glucose monitoring, which is better, because you can see in your mobile the way you are seeing that what is the temperature of Goa just now, you can see, or what is the time, the similar way you can see your glucose reading also. But you have to educate the patient for the same, because you should know the patient should also act for the report. He should not come after 14 or 15 days or after 2 months that my all reports were about 250. Even I am using continuous glucose monitoring. What's the point of using that CGM machine if somebody is keeping the sugar more than 250 in last all the day or last 3 days, 7 days, 10 days. So you have to empower, you have to educate the patient. This is one of the paper which is talking that in a 6-month measure, if patient is using real time in compared to intermittently scan. Now, if I am telling something that real time is better than intermittently scan, somebody may say that where the evidence is. Yes, here is the evidence. You can see that a 59.6% time the person will be in time in range in compared to a person who is using intermittently scanned continuous glucose monitoring. The A1C difference between both the group will be 7.4 versus 7.1. But the most important thing is the severe hypoglycemia. And you can see the person who is using real-time continuous glucose monitoring, the risk of hypoglycemia is only 0.47% in compared to the person who is using intermittently scanned is almost 84%, 80.84% for the severe hypoglycemia. This is the continuous glucose monitoring recommendation by American Diabetic Association in 2022. So we started talking about 2005, and now we are talking in 2022 what American Diabetic Association is talking about it. We know that we all follow EDA, we all follow the international guideline, and we also have our Indian guidelines, and where again in this year when we are going to have in 2023 our guideline, we will be also having the statement on a continuous glucose monitoring. It is the 14-day continuous glucose monitoring, assessing for time in range. The glucose management indicator is recommended for glucose management. So it's no more only A1C. I'm not saying that you throw A1C. Self-monitoring blood glucose level, A1C and continuous glucose monitoring, probably I can say they all three are complementary to each other. But 14 days CGM is recommended by American Diabetic Association for a good glucose management. CGM recommended for all adults who take insulin, mainly who are on basal only, even on the basal bolus. They are talking of our type 2 diabetic patients, because those patients who are on insulin, and in India we are many of our patients on sulfonylurea, which can increase the risk of hypoglycemia as insulin. There is an automated insulin delivery device which is available in India also, with continuous glucose monitoring is recommended for children with diabetes, those who are type 1 it is recommended that they should use the CGM along with AID, which is automated insulin delivery system. That is what is recommended by American Diabetic Association. And when used in setting of clinical trial or when clinical circumstances such as during a shortage of personal protective equipment required, CGM can be used to manage hospitalized patient also. So somebody who is in hospital, who is not in ICU, who can be also monitored continuously with continuous glucose monitoring. And that's the real advantage, because the patient who is in hospital, otherwise we have to get his sugar multiple times, and that you can save his multiple prick by using a continuous glucose monitoring. Those patients who are not very sick and those patients who are not in ICU, they can be used with this. The ACE also recommend the same. So, I mean, American Association of Clinical Endocrinology, in a different language, they are also talking that continuous glucose monitoring is recommended, not only for type 1, for type 2 diabetic patients also, and to decrease the risk of hypoglycemia for patients who are on insulin or sulfonylurea. But not only for that, but also for empowering, for educating, for motivating the patients, for even changing the therapy also, a continuous glucose monitoring is really very much required for those patients. The significance of CGM in patients with diabetes: discover previously unknown hypo and hypoglycemic events, useful in trend arrows, that is very important, value of metrics such as glycemic variability, time span, that is time in range below a targeted glucose level, time above range, and time in range. To know all those things, determine the effect of glucose lowering therapy, to know that how much insulin is going to make the difference. Like we were talking about that one type of insulin, when we compare with other, can we have a two comparison? If we don't do the continuous glucose monitoring, probably we can't do for that. Evaluate the effect of exercise on a glucose control, provide the behavioral intervention based on a real-time glucose value to individualize the management of the patient and analyze the glucose effect of targeted pharmacological intervention, whether fasting and post-meal glucose level both. In a clinical insight, I just give you one or two examples that CGM, when it was compared with blood glucose monitoring, resulted in a significant lowering HbA1c level at 8 months. So we have evidence to show that why we should use the CGM over SMBG, and this is the data which I am showing, that there is a significant reduction not only for the HbA1c, but also you can see the risk of hypoglycemia is also getting less. Even the benefit of CGM, many of clinicians, they feel that CGM is to be used only when patient is going for insulin pump or when somebody is going for an advancement in therapy. It's not like that. To understand many more things about the glycemic trend, about the glycemic variability, to know about the hypoglycemia, I think continuous glucose monitoring is altogether separate. It is nothing to do with only with pump. And that's the reason in Diabetes India, this time we had kept a workshop, not combined with insulin pump or advanced insulin delivery devices. It is a dedicated workshop only on continuous glucose monitoring to reduce that how much HbA1c reduction is there, 0.78%, 21 milligram deciliter lowering the average sensor reading, and 11.2% more in time in range with the patients who are on a continuous glucose monitoring along with multiple daily insulin injection. The real-time CGM user improve the time in range compared to SMBG user. Evidence of real-time CGM efficacy in type 1 and type 2. We also have the data for type 2 diabetic also patients, and there I had shown you that evidence of real-time continuous glucose monitoring device in a benefiting for type 1 and type 2 both. Real-world use of this, there is 308 young people with diabetes, 75% were using CGM while only 25% were using SMBG. The real-world study also support the use of continuous glucose monitoring in type 1 and type 2 diabetes independent of their treatment design, whatever the treatment which they are taking, still they had used. And to last slide, the take-home message: the self-monitoring of blood glucose measurement do not capture the post-meal blood glucose spike, while continuous glucose monitoring capture post-meal spike and glycemic excursion across the day. CGM provide information about the glucose concentration as well as trend information about the direction and rate of changing glucose concentration. Guideline recommended the use of CGM in diabetes management. Numerous randomized control trial had demonstrated benefits from using real-time continuous glucose monitoring over SMBG, including lowering of A1C and reduced hypoglycemia. Thank you. Thank you very much. Thanks, Chairperson. And we will have discussion at the end that will be better, and we will show the device also. Thank you. I can see here also. So don't worry about it.
अरे सर, no, no. Thank you, Bansi sir. After this very good lecture, I think now it is time for
RX
Dr.
event,
Manoj
sir.
Chawla.
Manoj Chawla.
He is going to speak about
Yeah, na?
focus on time in range through CGM to target better clinical outcome in diabetes. To introduce Dr. Manoj Chawla, after doing diploma diabetes from
Naidu.
Nair Hospital and Mumbai University, he has done fellowship in RSSDI as well as FRCP from Edinburgh. He is director and consultant diabetologist at Lina Diabetes Care and Diabetes Center at Mumbai. He is also consultant diabetologist at Raheja Hospital, Fortis, then Municipal General Hospital, Andheri. He is organizing secretary for Diabetes India Conference 2022. He is also honorary visiting faculty at D.Y. Patil Medical Sciences, Navi Mumbai. He has also awarded RSSDI Fellowship for the year 2017 and Fellowship of the Royal College of Physicians of Edinburgh for the year 2019. He is principal investigator in various global MNC clinical trials for NCs and devices. He is member of the Technology Task Force for RSSDI National. He has awarded, or rather, he has done papers in more than 25 national and international journals. He is also associate editor of International Journal of Diabetes in Developing Countries.
तो फिर
So, over to you, sir.
Thank you, Chairpersons. First of all, I'm extremely overwhelmed by the response, and Bansi and me have been talking about it. The technology and CGM workshops need not be in workshop halls, but they have to get to the main front, and which is what we have planned for all of you. We will have the DTech conference next year, third week of March, which is going to go big and national. We had an online one, but we'll be doing an in-person, and probably it will be in Goa again, third week of March. Well, we'll have the best of international and national faculty focusing on technology in the use of diabetes. So Bansi spoke to us about the migration probably from SMBG to CGM. I'm going to be focusing on TIR. So as we understand, there are many phases of an A1C. Today, though HbA1c is still the strongest endpoint metric that we have for long-term diabetes control, HbA1c doesn't give us the whole picture. There would be many individuals with the same A1C but completely different glucose profiles. So gone are the days that we can just sit back on an HbA1c and manage diabetes. It can be done in few patients, but in many we would miss out the variability. And which is where the time in range, which largely is derived from CGM, comes into place. An AGP report today will carry the metrics of time in range. In fact, today, time in range is now becoming a part of most software reports of all CGM devices, be it Medtronic, be it the Abbott. I'm sure when Eris gets its own, which we are going to do a demo today, when they also come out, their software will also incorporate the time in range. In fact, you can actually calculate time in range through SMBG also. It's just that for that time in range to have some accuracy, you will need to have far more frequent SMBG. So at least a 7-point, preferably a 9-point SMBG, and all of us realize that it's going to be difficult. You may have one motivated patient who may do it 7-9 times, but not too many who will manage to do that. So time in range can be derived from there, but doesn't happen, in which is where CGM becomes the means of doing that. So this is the AGP report. As we understand, the median is the line that you see there, and then you have the interdecile and the interquartile range. So the AGP report is basically, to simplify that, when you get CGM data basically is the sugar movement over a 24-hour period. Each day line is going to be plotted. If you plot it between 12 a.m. to 12 a.m. over a 24-hour chart, you will see the sugar movement on each day. Now, when you superimpose these lines, if I'm doing a CGM for 7 days or 14 days, each of these lines will get plotted on top of each other. So in the past, when we were using CGM, these lines plotted over each other sometimes would be completely variable. Now, when you do a CGM as a physician, or when a patient sees that, the idea is to understand their profile. But in the past, when we didn't have this software, the CGM sometimes would still not help because you would see too many ups and downs. So how do you make the changes? And this is where the AGP came in. A lot of people think AGP is another CGM. It is a specific. No. AGP, which is ambulatory glucose profile, is a software simplification of your CGM lines. Right? So when you have these lines all over, to compress that and to give us a report where we easily understand it is what is AGP. AGP is a patented software by International Diabetes Center, which they then lease it out, or they rent it out to any of the software companies who want to buy it from them or who want to license it. This AGP is a percentile form. So 50% of the readings which are at one point will give you the median, which is the center black blue line. The remaining between 10th percentile and 90th percentile, the 80% of the readings would be the light blue shaded portion. But all of you understand that when your patients do their sugars, one odd day somebody would have eaten, one odd day somebody would have exercised more. So there will be an occasional high reading and an occasional low reading. When those readings are very few, those fall into the lower 10 percentile or the upper 10 percentile. So we all understand percentage better. Percentile we do understand, but we as doctors are not so programmed on the percentile. But this is a percentile system. So which is where it makes it easier. That means we focus more on the median and then the blue shaded portion. The light blue shaded portion up and down is more related to patient's behavior, which happens on one odd day when the patient went wrong in terms of food or delayed the meal and on the lower strata had a hypoglycemia. So when you look at the reports, you will see individual day reports also. So all of us have started asking for doing CGM. Some do it directly. Some you have companies who are offering, just like the ABPM, they offer that they will do it for your patients. We do have a couple of chairs ahead. Please make yourself comfortable. And as Bansi said, those who want to use the carpet, please be our guest. We apologize that it's packed, but you are overwhelming us with your presence. So thank you. So each day when you're doing those reports, at least start spending some time with the patient on that report and understanding that report yourself as well. So you will have the individual day readings. Now, the time in range, which is largely recommended for most people with type 2 and type 1, is between 70 and 180. In pregnancy, it goes down to 63 and 140, and then you may also have relaxations that you may want in some patients. And so you can set it in the software. If you don't set it, the standard would be 70 to 180. When you download the data on the software, you have the means of changing that. Now, if I have a patient who is extremely determined and wants to try and touch closer to 6% HbA1c, we may probably keep a 70 to 140 for that individual as a range. But the larger recommendation, or unless you change it, it is 70 to 180. So anything which is going to go below the preset range is going to come in red, which signifies hypoglycemia. And anything which is going to go above 180 is going to become yellow, which is hyperglycemia. Of course, there are recommendations today as to how much is acceptable within range, largely 70%. How much is acceptable above range? Because it's not that you won't go. A person with diabetes will have food, may have something. It's not that every sugar will be below 180. He or she will touch up to 190, 200 for a short duration and start coming down, which is acceptable. You cannot have 100% time in range. If you are a person with diabetes, very few will have that. So a certain percentage, which is 25 to 30 going above range, is acceptable. In the hypoglycemia, it should be less than 5%. Less than 1% should be below 54, which would lead towards severe hypoglycemia. Having said that, every time we'll hear an argument about, is this genuinely true? So many times patients have seen the red and they have done an SMBG, but they found it to be 75, whereas the CGM is showing a 60, 65. Yes. Technology evolves. Is this 100% accurate? No. If today you do between your sugars between different glucose meters, you will see some variability there. If your patient goes to 5 laboratories on the same day, you will see differences there as well. So there is always going to be a difference. 10 to 15% MARD value, right, which is mean amplitude of deviations, is what the FDA recommends. So less than 15% MARD value, you get the FDA recognition. Of course, the newer sensors have now dropped it down to 8%, which means the variability is still there. There will be difference, but it is lesser. But having said that, if somebody sees an hypoglycemia and doesn't feel that, they may have to cross-check with an SMBG in some situations. And of course, it's also to do with day 1 and day 14 on most technologies. If you're using a 14-day technology, it takes a warm-up period, and by 14 day, it may be wearing off. So take the day 1 and day 4. Now this being a workshop, I'm trying to give you some other tips which go beyond just the theory of the entire CGM. That day 1 and day 14 take with a pinch of salt. Right? It may not be the most accurate data on day 1 and day 14. So again, this is about the questions. Do we wonder why do we need monitoring tool beyond A1C? I think Bansi's told us that. Glycemic variability is the, and when we talk about glycemic variability, you have the intra and interday variations. So what is intraday and what is interday? Let me go back to that CGM AGP picture. When you have this AGP picture, somebody who's wearing within a day, so this is a 24-hour picture. This whole thing is a 24-hour picture. Now within the 24-hour picture, within the 24-hour picture, this individual is probably okay here in terms of the median, spiking after breakfast, coming down, spiking again after evening supper, right? Now this of course is not an AGP of an Indian diet. We don't have supper, we have 4 meals a day or maybe more. So we'll see different peaks. But this is basically signifying the intraday variability. Within a day, this individual is varying up and down. We would love to see a flatter line with just smaller peaks around the meal time. But this individual is definitely having a lot of intraday variability. What is interday variability then? The interday variability comes from the width of the AGP report. So even if I ask you to not look at this shaded portion up and down, the extreme light blue one, and you are looking at just this shaded blue portion, what do we want it to be? We want it to be a thinner line, what I always call as a small, thinner snake. And we don't want it to be a python which is gobbling up food and become wider. So if this is wider, that means there is interday variability. So if I see an individual, let's say it's 6 a.m. At 6 a.m. this person's sugar is going from 65 on one day to closer to 160 on another day. That is interday variability. There will be some variability, but thinner the better. Look at this person at this point in time. Again, so this is more interday variability, and then you are appreciating the intraday. So we want somebody who's not being too variable day to day, and even within the day they shouldn't be too variable. That will be an ideal profile. So metrics for glycemic variability, allow me the freedom of rushing through the theory part so we can have some discussion. So you have had multiple metrics. Today it's coming back to coefficient of variation. Now this comes fresh from ATTD, where Bansi and me were there a few weeks back, that what is largely going to be considered as a metric for variability. Please understand, because these terms are going to be coming up all the time. Glycemic variability, the ideal metric which is being used is coefficient of variation, especially for regulatory approvals by FDA and others. Time in range is a wonderful metric, but it will remain a clinical metric for us to treat patients. The FDA as of now has not accepted time in range as a regulatory metric. Right, Bansi? I think Bansi was there in that meeting and part of the committee. So this is the ATD consensus statement, which talks about how do we reach that point of what is the recommendation. For some of us to understand, you know, when we talk to our patients, the first time we spoke to them about HbA1c, somebody would have asked you, "Ye 7.5% kya hai? What is 7.5, 8% or 7%? What does it mean?" Because our patients are used to numbers of 140, 160, 180. So we had to tell them that 7% means close to 150, 154 ka average over the last 3 months. If you maintain that, you will get closer to 7%. So you have to educate them. How will they know what is 7%? Same way today, they know HbA1c now, but we are moving one step ahead. So how do they understand time in range? So we tell them that if you are going to be spending 70% of your time within the range, you will probably be closer to an HbA1c of 6.7 to 7%. And as you can appreciate here, for every 10% increase in time in range, the HbA1c will improve by about 0.7%. But having said that, these are approximate estimates based on certain models. So again, glycemic variability and risk of non-severe hypo, multiple. Sometimes people question that, really you guys are talking about glycemic variability. Is there a genuine concern? Or you all are just creating this new metric of variability, just like the WhatsApp chats on LDL cholesterol levels and God knows what all, entire diabetes is a scam. Glycemic variability is true. All of you, and I can see many seniors who've been treating diabetes for much, much, much longer than we've been even born. You would have always come across patients and thought that this person always had 10% HbA1c, sab kuch kiya masti, but never landed up with any complication. And you had another person who always said, who comes to you, who has nephropathy, has some retinopathy. Doctor, you've been treating me for last 10 to 15 years. My sugars were largely reasonably controlled, but why am I landing up with complication? Of course, there are many other factors. There are some going to be genetic preponderance, which we will learn in the future. But one of the possibilities always has been the variability leading to oxidative stress, leading to these complications. So some food for thought. Glycemic variability is there, and it creates problems. Implications have again been shown through many trials. DEVOTE was the cardiovascular outcome trial for degludec. And that again showed the link between glycemic variability, oxidative stress, and the risk of complications. There is evidence also for time in range and microvascular complications. The way we talk about UKPDS, DCCT, 1% reduction means how much reduction in complication. There is evidence for time in range, that improvement in time in range will reduce the complications by a certain percentage. Of course, this is not direct evidence. This is based on mathematical models extrapolated again from the DCCT time era, that they have had this model and displayed that. But there are many studies now focusing on TR, and as I said, if not for regulatory purpose, for clinical treatment purpose, it has become a very useful tool, which is time in range. Also evidence for time in range and carotid intimal media thickness. So talking about not only microvascular, but possible connection with macrovascular complication. Now that's a different thought today, that people are actually questioning macrovascular complication. This is not related to the topic, but I thought I'll bring it up. Researchers world over are questioning that is cardiac disease a macrovascular complication. They are now showing evidence that diabetes is affecting the microvasculature even in the cardiac and the carotid systems or the cardiovascular systems much before it becomes a macrovascular disease. So everything that we have been thinking about as a large vessel disease may actually be starting more as a small vessel disease. There's a lot of work going on, and you'll hear more of this interesting data and research in the years to come. So there continues to be an association between derived time in range and the major adverse cardiovascular events, which is MACE, that we see in all cardiovascular outcome trials. Again, data for 10-year evidence. These are thoughts from as to, again, the derivation from the DCCT UKPDS studies. Hypoglycemia, extremely important factor why we want to do CGM and start looking at time in range. And glycemic variability is definitely becoming a clinical target for all of us. Yes, we can all sit back and say, we are in limited resource, patient cannot afford. Well, when you are in limited resource, you don't even do HbA1c. So you manage with not even SMBG, but patient doing one fasting or fasting and post-lunch in 3 months and coming to you with one laboratory report, which is what used to happen in the past, and you were managing. But today, when you learn better, you do start asking for other metrics, because you know you're missing the point in many patients. So if India too has to change this profile from only 20% of our patients in target to at least reach 30 to 40% patients in target, we have to move beyond our conventional thinking. And one of that is looking at variability, time in range, and more frequent SMBG, of course. So when we say, what do we want in our patient's AGP profile? We want FNIR. What is FNIR? We want the profile to be flat, as I said. We want it to be narrow, like that thin snake moving from left to right. And we want it to be in range, predominantly within that pre-specified range. So FNIR is the take-home mantra for all of you. So normoglycemia is the goal, and the one below is what we want to see. That this is all the profiles we want to have. In the interest of time, I will stop here and not get into individual AGP discussions or therapeutic discussions. Our idea is to keep strongly introducing the concept of use of technology in your day-to-day clinical practice, understanding benefits of CGM and understanding benefits of time in range, which is a useful metric. With this, I invite Bansi to come up for discussions, and at the same time request the team from Sarka and Eris. We also invite any of you who wants to get the CGM fixed onto themselves, whether you have diabetes or don't have, you want to do that, you don't have to disclose to us, but you can start using this. Eris and team would be happy to put the sensor onto you and give you the connection on the phone to start seeing the data. So any of you who you want to, they have a volunteer where we will use it, but any of you wants to use it also is most welcome.
One more announcement which I just want to do, as Manoj already told you, that it is the idea that more technology usage should be done in our country. And for that, we have already started a meeting, dedicated meeting only on diabetes and technology. And I'm sure before 2 weeks, many of you were the part of that meeting as a audience, as a speaker and all those things. And me and Manoj, along with Amit and Rakesh, if they are there, the next year we are planning to have one dedicated meeting only on diabetes and technology. And it will be again a 2 days and 2.5 days meeting, which we are planning to do again face to face at Goa. And that is what our plan from next year. It will be a dedicated diabetes technology meeting.
If you like this venue, we'll keep it.
Oh, yes.
Change it.
That's the plan, but that's what we are finalizing for that. Thank you. I think we should.
Yeah, so we wind up in 10 minutes as the next. Any volunteers?
Yes, right?
Okay, just forgot to tell you we're charging 5,000.
No.
I'm just come inside, Sir, yeah, exactly. वो पूछ लो, they're using you as a guinea pig, then you have to charge them.
Anyone have any questions? So,
Yeah, while they're doing this, the
continuous glucose monitoring is continuous. That's again a confusion. Some of them say think that how frequently you should do the same thing, that self-monitoring blood glucose should be done how frequently. When SMBG came, I mean, nobody was ready to do it once in a day even, and it is to be done before 3 times a day, because you are eating 3 times, you have to taking the insulin 3 times, and you have to do it like. So continuous glucose monitoring is a continuous glucose monitoring, mean 24/7 you have to see, and continuously you should do it. That is what recommended. Now, real-time continuous is to be done continuous. There is an intermittently scanned continuous glucose monitoring, that is IS CGM. We are using in our country, as many of our patients are not affording, so we do it this FGM or a professional one every 3 months, because that is what giving you idea, a prediction for next 3 months what will be your sugar trend. Dr. Pense wants to make some comment, I think.
Patients in the age group of 16, 17 to 21, they are very aggressive, different, and they like to indulge. Now, can they cheat CGMs?
I don't think, sir, the data can be captured. It can be remotely monitored. You can share the data.
Yes.
they cannot largely
No.
CGM, or they can, for example, has that limit. A lot of time.
Yes.
Apps in downloading.
Yes.
That's the time that they get scanned. This is a problem.
Yeah.
It's also a genuine problem in others who use it. What happens is the night time. So they will do it at dinner. फिर बैठे हैं, Netflix चल रहा है, सब कुछ 1 बजे सो रहे हैं. They get up in the morning and so they scan in the evening, 9 o'clock. Not scan at bedtime. Then scan it in the. They will miss I did mention, so above less than 30%, ideally less than 25, less than, and below less than 5%. Again, when we say less than 5, you don't have to have 5%, less than 5%. And if at all less than 1%, the below 54 range. So you have actually now level 1 hyperglycemia, 180 to 250, level 2 hyperglycemia, which is more than 2. Similarly, hypoglycemia is also two levels, 70 and 50. Level 1 hypoglycemia or time below range. Level 2 no, want to of course avoid patients less than 1%.
सर को कुछ माइक नहीं है क्या उनके पास
In the last 2
पूछ
years, even the
सर
India,
एक्सक्यूज
the
सर
standard in fact, ACE said that he also says you to use more of CGM every patient. That may extend, so they cannot see what happens in case you have to
शॉर्टकट पे स्क्रीन नजर आ रहा है
I personally are more superior to avoid starting medication. How a particular exercise, how a particular food is helping them. Now apps which are pushing it not even in pre-diabetes. They are pushing it in marathoners. You must have seen the guy in
माइक
the
पूछ
Thomas
रहा
Cup
था माइक
football.
दे दे
In his final match, he
तो
was
जाके
wearing
लेके
the
आना रे
so even he is not
बाजू से
tired.
जा
So one thing is
बाजू
for
से
any
जा वॉइस नहीं आ
guideline
रही
to
यूट्यूब
come
पे
in, it requires a lot of evidence. The evidence is getting generated for type 2 diabetes. But that does not mean it is not. And the second problem in American diabetes, if they put anything on the guideline, then it has to go for the insurance also. So these are the two major challenges, but that does not mean it should not go.
Sir, how,
खत्म हो गया हाँ हो गया निकाल ये फोल्डर खोल के प्रेजेंटेशन ऑन करके फिर निकाल आते ना प्रेजेंटेशन ऑन करने के लिए ओपन फोल्डर ओपन करके ओपन हुआ स्लाइड शो पे जाओ बिगिन फ्रॉम बिगिन क्लिक करके
yeah, sir, that change what you just described, patient will be doing some lifestyle modification looking into the readings. For the doctor, how often can he keep changing the medication to suit the requirement? That's what I'm using here.
उधर वायर हिला हुआ है ओके वो लोग क्लोज किए
We empower them to make changes. So for one, largely believe the role of the more don't spend that the time lives with their own self. So in those areas. So you empower them that on the what they were doing earlier on the basis of SMBG, then doing their carbohydrate counting, their insulin. Today they are doing continuous easier and they are adjusting their dose whether they're on the pump or on multi. There only helps in overview. Doctors role probably more professional patient with diabetes.
पुराना वाला क्लोज करके नया वाला करके कौन सा कोड है इसके लिए HDMI कोड चाहिए इसके लिए कनेक्ट है और अभी
And that there is no actual recommendation how to happen. Mansi will probably plan that at least an Indian consensus on what. But we have already done the Indian
Considering the time required for onset of action of a drug, insulin or oral medication.
enough data
Sure.
where we have shown that you
बिगिन फ्रॉम फॉर वैसे रहने ठीक है मैं जाके उस पर सेट कर देता हूँ माइक ऑन चालू के लिए
how the patient
माइक पास वायर
day one the time
वायर
about
पूछना
target
नहीं
was 80%. Obviously patient day 14, the time in range became 84%. You can track that. Somebody who's very petrified, and don't start me on medicine. I saw hypoglycemia in my mother. Even if you tell them you're not starting a sulfonylurea, a non-hypoglycemic, there will be some petrified. Don't worry, I'm putting this. You will be able to track it. So,
Yes, the scanning part I didn't understand. The patient has to do something manually.
That's real time again. It is Abbott Libre and Libre Pro. So the Pro is a professional one. When you have to use, there is a doctor. When you go to the meeting, they scan it and they get the report. While the the personal use, they can use their phone and they have the meeting also. And they have to do every 8 hours. Minimum before 8 hours they have to flash it.
right
And
now,
yes, here we want to show the real user and the continuous monitoring, how you can see on your mobile, and that's very important, I think.
so for doctor here, it's been fixed. This is not his reading. His will start on his phone after a while. So this is the demo one.
No, this is for the
For which, right. So, yes, so Raj needs to see his doctor and improve. I know.
But you told first day.
First day to take it. This
so
is
the
it.
post-meal glucose level is slightly higher.
So again, this technology doesn't require it for scanning, what they are using. It will directly transform into the phone. Some technologies require you to move the reader on top of the sensor. So,
So this is the sensor. You can see
and
here.
you saw that it was simple to put it up the way you did it. In case somebody else also wants to put it up, we'll do it outside the workshop hall. It's time for the next
It is in
diabetic
the
foot.
faculty lounge or boardroom. We can do it.
We can do it outside. So again, a big thank you to all of you for joining us here. Thank you, Bansi. And of course, Eris for the support for this workshop. And the chairpersons, Dr. Akshay Kothari and Dr. Rahul Dope. Thank you. Right?
An overwhelming response of the doctors who are coming here. Thank you.
Please stay back.
So the next